Hi friends, I am Dr. B.V. Rao of Usha Clinic and founder of the websites qmedicaldoubts.blogspot.com and raghavamedicaldoubts.com. Through these videos, I am providing the basic knowledge about the commonly occurring diseases, treatment and surgery details when necessary for the reference to medicals and general knowledge to the general people. Today I am going to discuss about the mastitis and breast abscess in Puerperium. The infection of breast in Puerperium is called the acute mastitis caused by the Staphylococcus aureus. Infection may enter the breast through a cracked nipple, but occasionally the infant may harbor staphylococci in nasopharynx, and infection occurs along the milk ducts. It may become epidemic in hospitals. Types of mastitis. The infection is limited to areola forming an abscess around the nipple. It may involve the lactiferous tubules when it is called parenchymatous or glandular mastitis. The bacteria may gain access to the connective tissue through a crack or deep fissure, burrows into the fat around the lobes and lobules and cause interstitial mastitis. It may be superficial or deep. The infection may pass directly through the gland to the areolar tissue under it and produce submammary abscess. Symptoms. The parenchymatous form is the most common and is seldom seen before the 7th day of delivery. Commonly it occurs between the 10th and 12th day. Pain, slight fever and sometimes chills opposite. The affected lobe is red and tender. One or more lumps may be palpable on the breast. Suppuration usually sets in if fever continues for more than 48 hours. A remittent temperature and chills along the affected portion becoming hot, tender and enlarged are indications of pus formation. Softening and redness of the skin at one point indicate where the abscess is pointing. Unless properly treated in time, successive lobes may be involved till whole breast is riddled with abscess. In case of cellular type, the infection spreads into the gland from a fissure. A fan-shaped redness may be seen spreading from the crack. The deep lymphatic glands may be involved. Suppuration is much more common in this type. In submammary abscess, the pus collects behind the gland and edema appears at periphery. The patient is more toxic, and unless the pus is evacuated, it may bury deeply and the patient may die of bacteremia. Treatment. If appropriate antibiotic treatment is started before suppuration begins, the infection can usually be aborted within 48 hours. Before starting antibiotic therapy, milk must be expressed from the affected breast onto a swab and cultured for identifying the offending organism and its bacterial sensitivity determined. Till the results are known, the treatment with penicillin G is recommended. Once the sensitivity is known, the concerned antibiotic must be used. Though the response is prompt, it is important to continue the treatment for at least 10 days. If an abscess has formed, it must be incised immediately. Sometimes the abscess cavity can be emptied by aspirating with a syringe with a wide bore needle. Then penicillin is injected into the abscess cavity. 5 lakhs units per 1 ml and enough should be instilled to fill the abscess cavity. These aspirations and injections are repeated every other day till no more pus is aspirated. Some patients can be cured by this simple procedure. Others require incision and drainage. One should not wait for the appearance of a fluctuation before opening the abscess. Persistent edema under such circumstances is quite a sufficient indication to warrant the operation. In the supramammary type, it matters little in which direction the incision is made, since the pus is always superficial to the breast tissue. In the true intramammary abscess, the incision should radiate from the nipple. One or more may be needed, and these should be freely made so as to allow the insertion of the finger to open up any pockets or lobules which are distended with suppurating material. The resulting cavity is loosely packed with gauze, which is removed at the end of 24 hours, and the cavity is repacked loosely with shorter pieces. Suppression of lactation is necessary when the chief incision is needed above the nipple. It is wise to make a counter opening in the lower half of the breast and generally on the outer side to permit of efficient drainage. The submammary abscess is best opened towards the lower and outer quadrant and is at anywhere pus points. That's all about the puerperial mastitis and breast abscess, and in the next video I will discuss about some other disease. Thank you.